Great. Thank you, Dr. Carol Scott and Dr. Kumanyika, for that terrific keynote and conversation. We're going to skip over the next mentee and move right into our next panel. So I'm going to turn things over to Dr. Laurie Whitsel from the American Heart Association, who's going to be moderating this panel. Dr. Whitsel.
And so great to be with everybody today. Such an honor to be on this panel with these amazing, this amazing panel today. I'm excited to introduce them, and then we're going to jump into the program. So we're excited to do an energetic panel for you today. First, Brian Elbel is going to talk today, from New York University Langone Health, and then Rafael Pérez-Escamilla is going to discuss his research with us, and then Angela Trude is going to really give us a great presentation of her work. So at the end of all three, we'll do some question and answers, a question and answer period, and then looking forward to wrapping up from there. So at this point, I'll turn it over to Brian to start us off.
Thank you so much, Laurie. Pleased to be here. Thanks so much for the invitation. So I'm going to talk to you today about some natural experiments and as they relate to childhood obesity and nutrition work. So next slide, please. Next slide. So I have nothing to disclose. Next. So natural experiments, why are they useful to study childhood obesity and nutrition? They are, let me just explain a little bit about what they are first. They're a research methodology that tries to take advantage of things that are already happening, right? Things that are already happening in a community, in a school, in an employer, and really does work to rigorously study it. And they're particularly useful when you can't get to randomization. The goal is to kind of perform an analysis, a set of work that gets as close to that really causal work as possible, as close as you might get with an RCT. And I think they're particularly important for the kinds of studies we're talking about here, given that we have a lot of policies happening here, both kind of big P policies, some of what I'm going to be talking about today, small P policies, an employer, a school changing what they're doing on an individual school basis. So it really is important to study those well, and I'm going to try to make the case as to why. Next slide. So how do you do a natural experiment? Basically, what it means is that you're determining what's happening in an area that's implementing a particular policy. You're looking what happens in a comparison area that looks like the area that implements the policy but didn't do it. And you're basically going to look and see, did one area change in a way that's different than the other area, right? Are there kind of differences in how communities or neighborhoods or schools look over time? Oftentimes, the kind of more technical term you might use for this is a difference in difference design. If you do one more click, a kind of classic example of this is, just one more click, is a Carden-Kruger study looking at the impact of minimum wage, right? So New Jersey impacted a new minimum wage, Pennsylvania didn't, and you sort of say, all right, what happened to employment as the outcome they're interested in here for the place that impacted it versus the place that didn't. So this is one of the kind of the classic examples outside of the obesity nutrition realm that you hear about when you think about natural experiments. Next slide. So what's really important for natural experiments is to think about this comparison group. It's really important that we choose these very carefully, because our goal is to, again, get as close to randomization as possible. And the idea is that you want to have similar trends in the comparison group and the treatment group over time before the policy is implemented. And if you click one more time, I'm going to give you a couple different examples of good versus bad comparison groups. So these sort of show you the blue line, what we call the treatment group, the area that got the policy, the red line, the comparison or control group that didn't get the policy. That kind of dotted line in the middle is when the policy starts. We're looking over time here. Think about this as being any outcome you're interested in. And in the first set, you see these like pretty good parallel trends, right? They're kind of chugging along pretty nicely. They're both going up, but they're both going up at about the same rate, and the gap between them staying consistent. The one in the middle is not so great parallel trends, right? The control group is kind of chugging up at a similar rate, and the treatment group's all over the place. And this third one is parallel trends that are kind of consistent for a while and then deviate over time. So it's really important that we find the right comparison group when we're thinking about natural experiments, and you want one that kind of looks like the one on the left and not so much it looks like the middle or the one on the right. And this will be important as we kind of think about having the right data to be able to make these comparisons over time. Next slide. So when and why might we use some of these, right? You really want to use it, as we said, when you can, where it's not feasible to randomize. And that's really what we're talking about, not for everything, but a lot of kind of at least big obesity policies. Um, I think it's also really important to look at these when we're really trying to understand how something's going to play out in the real world, right? We oftentimes see experimental studies, and I think those are really important to help lay the stages for a lot of these policies that might be implemented. And it's really important, I think, to kind of look at what you're doing and how these things really work in the real world. And if you do these well, you can get a lot of the benefits of a randomized system. Next. So a few limitations to consider, and we kind of alluded to this before, but data is really important here, right? Do you have or can you collect or can you get, and I'm going to give you some examples where we've done both of those things, data on the key outcomes of interest, whatever that might be, and can you get it really over time? Ideally, you need it, really at multiple points, ideally pre and definitely post, to understand what's happening over time here. You got to think about the type of data you're going to get and the power considerations there. For example, are you going to do some original data collection, and can you get a big enough sample to see the effect sizes that you need? Can you get in the field before the policy starts? And you heard some reference to some of the time-sensitive mechanisms that the NIH and other have that can be useful for this. Are you going to use secondary data, right? Data that are already there and available for you, which have pros and cons to them. Maybe they're going to be, have greater power to them, and maybe they're going to be measuring only some of the things you really care about and that are important. Do you have a good comparison group? That's, again, really important there. And all those comparison groups have similar baseline trends. And then finally, generalizability. Are you studying this in one particular location? And is that going to be generalizable to other locations or not? So these are all some considerations and potential limitations of the designs of some of these natural experiment sorts of studies. Next slide. So I'm going to walk through a couple of different examples of how we've implemented these in the past. I'm going to start with menu labeling. And we've done really two types of studies here. One is where we, in our early stage work, we were outside collecting receipts from fast food restaurants after they implemented menu labeling. And the second example I'm going to tell you are using transaction level data from a large national chain. Next slide. So the first one is we went out and we collected a whole bunch of data, right? From both New York City's labeling law, over 1,000 receipts, where we use Newark as the comparison area there. The second study, we studied Philadelphia's menu labeling law and used Baltimore as a comparison group and got over 2,000 kind of receipts there. And again, the design is go in before the policy is implemented, go in after the policy is implemented, and look for a change in one area, New York or Philly, as they compared to the comparison areas, Newark or Baltimore. One more click. And what you see here is one example of what we did when we studied New York City. Sort of the darker red are restaurants that had calorie information. The lighter red are restaurants that didn't. We went before, after, and then sort of 5 years later, really, to look at the influence of some of these policies. And what we found is that there really wasn't much of an impact, that we could observe, at least with the power of the study we had, to look at the influence, that we were able to see kind of an appreciable impact of labeling. But what we realized from this study, which was an earlier stage study, is that these impacts might be pretty small, right? They may not be something you're going to see from a particularly smaller powered study. So if you click one more time, I'll talk to you about it. Another way we did this, right? And this is data from a large fast food retailer that we were able to get. So instead of 1,000, 2,000, which were tremendously difficult to get, we suddenly have over 5.2 billion transactions, and we were able to study 474 different locations that implemented menu labeling, each restaurant with its own really well-matched comparison group from across the nation. And if you click one more time, we'll see the results from this study. And you see, first of all, that these kind of parallel trends in the baseline period, those lines are sort of exactly on top of each other because we were able to do really nice matching from a really large sample. And you see in the post period, there is something of a deviation here in terms of the number of calories that were purchased. It's about a 20-ish calorie impact in the first year, closer to 30 in the second year. So we did see something of a change here in terms of the number of calories purchased, and we weren't able to see it when we were collecting our own data. We were able to see it when we were using secondary data. So we can talk about the impact of this sort of size of effect, but it was important to be able to kind of see the potential difference there. One more click, I'm going to tell you about the next set of studies we looked at, which is new supermarkets coming into locations for tax credit reasons. And we studied these in New York City. Again, an earlier stage work, we went out and collected data from a community. Our second round of work, we were able to use administrative data to do this. If you click one more time, the first study we looked at and studied one store, right? It was that store that had the red supermarket sort of cart in there, the yellow are the currently existing supermarkets. All of the purple dots there are where we collected data from. The intervention community was the one on the right. The comparison community was the one on the left. Down at the bottom, you see Yankee Stadium there, just for a sense of scale. This is in the South Bronx. And we collected, again, lots of data from lots of people, over 6,000 surveys, almost 2,000 dietary recalls. We went before and just after, 1 year after the store opened, and we didn't see any change, right, in fruits and vegetables purchasing, except for those who lived really close to the store, right? And it would be exceedingly hard to try to get the right data just in a data collection like this, just from people who live really close to the store. So if you click one more time, what we did do is we did the study again and studied not just one, but these 8 different stores that you see here on the screen that opened as a result of city tax credits. And we were able to use data from not just that we were collecting, but from the New York City Department of Education, started collecting height and weight on all the New York City public school kids. And so we were able to track kids before, the same kids before and after these stores open, compare them to kids who were similar and in similar neighborhoods, but didn't live close to a store that opened. And we actually found that, there was some impact of a small impact of the likelihood of a decreased BMI-Z score, likelihood of obesity, again, for folks who lived really close around these stores. So again, we were able to see something here when we weren't in some of the earlier. Let's click 2 more times, please. We're going to skip over some of this individual results for time and go to a couple more examples. So newer stage work that's not actually out yet, but I want to give you just another example. In this case, we're using the same fast food retailer data to really zone in on soda taxes in fast food restaurants and sort of say, how does this work? In addition to just one city or state, we can look at kind of 5 different localities that implemented these taxes, again, before and after. Still under review and in process, but what we're seeing so far is no super substantial changes for fast food purchases as a result of cities implementing soda taxes in a way we wouldn't necessarily see if we were able to kind of go with a primary data collection or had a smaller scale study. One more click, and this is where we're able to locate those. Those are the red dots. It's sort of like all over the nation in a way we wouldn't be able to see if we were to kind of be on the ground collecting data. Next slide is about one other example with my colleague Marie Bragg, where we actually, in this case, are studying, are collecting individual data, right? So this is looking at a new grant that we did actually get from the Rapid Response Mechanism from the NIH just a few months ago. Lots of cities and states are now implementing restrictions on how kids are allowed to access social media. We're studying Texas and Louisiana's restrictions on that and looking to see, are kids seeing fewer or different ads on about unhealthy food and beverage advertising as these laws are being implemented. These laws are not only restricting access, but they're restricting potentially how the algorithm is able to access kids and advertise to kids. So this is a case where we actually didn't find the data currently available. And so we did have to go and collect data from kids ourselves. So there are still times where this primary data collection is really, really needed. And we've just done the baseline collection here. 700 screen recordings from kids recording themselves using social media or other things online. And we're going through a process right now of coding each of those. Next slide. So a bit of reflections, so why do we need them? I think it's really important to continue to work to understand the role of these policies, before they're implemented with things like lab experiments, modeling work, some thoughtful non-causal studies potentially. But I don't think that substitutes for the need to understand how these are playing out in real world settings. And these make the natural experiments really, really important. And I think these are really quite powerful tools that we should be using a lot more and should be part of any novel policy implementation, I would argue. Next slide. So these are still really hard to do well, right? And as I showed you, the comparison groups are really, really important here. And we got to give some serious considerations to getting this right. And we have to make sure we're getting the right kind of parallel trends there. And these are really, really important there. You really do need to have the right power to do these well. I think more funder attention to these things are going to be really important over time. And we also kind of really, I think, have to look for these larger scale administrative data to really understand what are out there, how can we use them more? And we've been able to use a couple different data sets to do that. Next slide. is thanks to our funders here, largely the NIH, but also a few other foundation funders as well, including the Robert Wood Johnson Foundation. And I'm looking forward to the discussion and questions. Thanks for having me.
Brian, thank you so much for that fantastic presentation on the importance of natural experiments. Really looking forward to our conversation at the end. I'm going to turn it over to Rafael next for his presentation.
Thank you very, very much, Laurie and colleagues. I have learned a lot today, and I want to share with you our recent experience that highlights the importance of community-led co-design of food security interventions. So I will talk to you about the community co-design and pilot implementation of the Food for Moms program, which is a produce prescription program for pregnant Latinas. Next, please. I do not have any conflicts of interest to declare. Next slide. This work is a full partnership between Wholesome Wave, the Yale Griffin Prevention Research Center, and very importantly, the Hispanic Health Council, an amazing community-based organization that has been functioning for 40 years in Hartford, Connecticut, and that they became the lead voice for this project. This project has been funded by the USDA GOSNIP program through Wholesome Wave, and I would like to deeply acknowledge all my colleagues with whom I've had the honor and pleasure to work on this project across different organizations. Next. So the reason for focusing on pregnant Latina women, of course, in Hartford, Connecticut, through a produce prescription program is, first of all, because food and nutrition insecurity during gestation is a risk factor for poor pregnancy and actually longer-term outcomes for the offspring as well as for the mom herself. Food insecurity is much higher among Hispanic immigrant pregnant women and among Hispanic families that have young children, and the need to combine produce prescription programs with nutrition education to increase fruit and vegetable intake as a part of food security interventions. Next. So the specific objectives of the Food for Moms, the Food for Moms project was first to co-design with the community, led by the community, produce prescription program for low-income Hispanic women, and then to pilot test the implementation and feasibility of the co-design program, and to do a preliminary assessment of the impact of this program on produce purchases and intake. Next. So our community engaged methods were the guiding road for the three phases of the project. First, we did a qualitative research co-design phase that involved very, very strong interactive input from partners. Then we did the pilot feasibility phase to find out if the program actually was not only implementable, but also feasible and likely to be sustainable. And then in the last phase, what we're calling the impact evaluation phase, in which we find ourselves right now, is really to figure out what was the impact of this intervention on produce purchases and intake, and to prepare to prepare ourselves to contribute to program dissemination. A very important role of studies like these that are done on a small scale, but that are very community engaged, is to actually end up informing policy at the local, state, and even at the national level in the context of the strong support from the federal government and many states for food as medicine or food is medicine programs, as we like to call them. Next. So the participants to be included in the study, they had to be Hispanic, living in the city of Hartford, and pregnant or with a child under 2 years of age. This is for the co-design phase. The recruitment happened through the Hispanic Health Council maternal and child programs in close partnership with the WIC program that actually has an office within the premises of one of the buildings from the Hispanic Health Council in Hartford. Next. So the co-design method was based on conducting listening sessions where participants were consented and administrated a brief socio-demographic survey. And then we used a semi-structured guide with open-ended questions to try to understand the participants' knowledge and perspectives on nutrition. And as we move on with additional listening sessions to actually present to the new listening group what the previous group recommended in terms of program design and get their feedback. And actually, the main goal of these listening sessions was to help work out the nuts and bolts of each program step, including recruitment, methods, incentive options, the places to purchase the produce, and so on. All listening sessions were moderated by one bilingual facilitator, which it was myself, and participants were paid $25 for their time. Next. So this is the very simple representation of the Food for Moms program impact pathway that really shows the key steps that represent the journey that each participant would need to go through in this program to be able to benefit from it. So it starts with community outreach. People need to be able to know that this program exists. Then there needs to be screening and recruitment if they meet the criteria for the program. Then they needed to engage in a SNAP ED nutrition education program that has been in place at the Hispanic Health Council for 30 years now. And then once they attended their nutrition education session, they were enrolled into the preferred approach that they wanted to be able to get their produce. Then produce redemption was assessed, produce purchases, and produce intake. And through the listening sessions, the participants contributed to work out the nuts and bolts of each of these PEEP boxes. Next. So we were very careful to not move forward until ourselves, as researchers in full partnership with the community, the Hispanic Health Council colleagues and others, until we were fully convinced that our program, at least on paper, it would have enough dosage or would be able to provide enough incentives for the participants to actually end up accessing and consuming more produce. And that's where we use the COMBI model. Next. So this is just to give you a sense of the characteristics of the participants that participated in the listening sessions. And as you can see, we were right on target in terms of the population that we wanted to be represented through these sessions. Next. So in terms of the feedback from the listening sessions, it was very interesting to see that the participants felt nutrition during pregnancy was incredibly important for themselves, for their babies. And they also acknowledge the fact that in these days and times, with all the price barriers and so on, it was really going to be well received, a program such as this one by the community. Next. They also gave a lot of feedback on the incentives and we were able to confirm that they felt the amount that was being considered was good enough and it would be provided for long enough for it to make a substantial difference for them and their families. And they also confirmed that it complemented, it didn't overlap what they were getting through the WIC program. Next. It was very also important for us to hear from them that they not only thought nutrition education was important, but several times they said it was really, really important that this nutrition education be made mandatory, because it didn't make sense just to give the produce prescriptions if people didn't know essentially how to prepare healthy meals, and they were making a lot of recommendations on how to make cooking demonstrations and make very community-friendly group activities to run these nutrition education sessions. Next. So in terms of the final co-design that ended up being pilot tested, the program included $100 per month in incentives for 10 months. The two options that were offered were Fresh Connect card for them to purchase produce in either Stop and Shop or Walmart. That's what ended up working well at the end of the day. But we also give them the option for produce to be delivered in their homes. But that was that was not very popular. They basically felt they themselves wouldn't choose that one, but that some moms in their communities may benefit from it. At the end of the day, they were right. And very few women actually ended up choosing the home delivery. So they endorsed the nutrition educations, gave a lot of feedback on how to run them. And also they agreed that it was important for women to enroll during the first or early second pregnancy trimester to truly benefit from this program. Next. So at the end of the day, with the community engaged approach that we used, we were very successful at being able to reach agreement with the target community members on the co-design of the project. The feasibility phase, the pilot phase, showed that not only that it was very feasible, but there was a very high level of program satisfaction with the moms. And we're almost done with the impact evaluation phase. Next. And at this point, all that I can share with you is that the preliminary findings show that the produce prescription redemption rates are quite high, about 90% of the amount, monthly amount is being redeemed, very high nutrition education session attendance. It's mandatory that they need to do it to actually get their benefits, and very, very high level satisfaction and good suggestions for improvement. Next. So in conclusion, Food for Moms is an example of how person-centered co-designs can support high produce prescription program uptake and compliance. Thank you.
Rafael, thanks for that great presentation on Food for Moms. Such important work, and excited to talk more about it in our question and answer period. Angela, I'm going to turn it over to you next.
Thank you. I'm very excited to be here today. It's an honor to be presenting. Today, my talk will focus on from clicks to behavior change, improving equity and food access through online grocery shopping, which is a work we've been doing mostly in urban communities in Maryland and New York. Next slide, please. I have no disclosures. Next slide. Thank you. So for millions of individuals in the US, especially those living in low-income communities of color, finding healthy foods is not so easy. Food service grocery stores, farmers markets, and other vendors that sell fresh fruits and vegetables and other healthy foods cannot be found in their neighborhoods. Or if they are there, prices are just not affordable. But what can be found, and what often in great abundance, are convenience stores, fast food restaurants that sell mainly cheap, high fat, high sugar processed foods, and offer very few healthy food options. In a national survey with more than 4,000 individuals receiving SNAP, the most common barriers to healthy eating were associated with living too far from a grocery store or not having access to reliable transportation to get to a store. Next, please. Online grocery shopping is a growing service that potentially addresses distance and transportation barriers by bringing foods to families. However, other barriers remain for low-income families. So, for example, many stores still require the use of a credit card for online transactions, and the additional cost of delivery is significant for those who shop on a budget, thus widening the gap of healthy food access. The USDA SNAP Online Purchasing Pilot, or SNAP OPP, tried to address the payment method barrier as an effort to promote more equity in healthy food access. However, online fees like delivery, service fees are still a barrier for most individuals. Next. So the research I present today sought to answer the following question: what are other factors that we need to address in order to improve equity in online grocery shopping? Today, I will walk you through these 5 steps of how we designed, implemented, and evaluated a policy, systems, and environmental intervention aimed at improving equity in online healthy food access. Next, please. So first, we selected a framework, and we selected the Getting to Equity framework to help us think through equity in the online grocery environment and to consider equity in the selection and evaluation of our intervention. So the framework has 4 quadrants that are complementary to one another, with potential for policy and systems change and opportunity to improve community resources and capacity. Next. Then we conducted a systematic literature review of online grocery shopping studies conducted only among individuals of low income. So we found in the online food context that online grocery services had been used to increase healthy food options, and SNAP, WIC, fruit and vegetable prescription programs had been tested to improve socioeconomic resources, again, in the online environment. Next, please. Delivery fees, high cost of healthy foods, and targeted online marketing were the main deterrent factors to online food access. And to build on community capacity, studies targeting individuals with low income underscore the need to improve consumer control and impulse purchase online. And some had tested healthy default shopping carts. Next, please. We also found that for the online food access context, it's still important to consider psychosocial factors that influence behavior. So a theory that has been widely used in online grocery shopping studies to explain behavior change is the theory of planned behavior, which was added to the middle of our framework, highlighting how perception of behavioral control could influence or explain healthy food purchase when exposed to other different factors. Next, please. So with funding from the Healthy Eating Research at the Robert Wood Johnson Foundation, we sought to understand families' online grocery shopping behavior in Maryland. So in 2021, during the pandemic, and with the expansion of the SNAP OPP, we found that families with low income were actually getting some or all of their groceries online. And those receiving SNAP benefits had used their SNAP EBT card online. However, when shopping online, they reported being less likely to select fresh fruits and vegetables or other healthy foods, as you can see in the example receipt on your right. Furthermore, there was still almost half of participants who had never tried to order groceries online, either because SNAP was not yet accepted in their retailer online, or because they simply didn't know they could use SNAP for online purchases. Next, please. We then consulted with community members to understand what factors and domains of the equity framework were applicable and important for our population to access healthy foods online. We conducted focus group discussions and in-depth interviews with 25 families with low income to understand the barriers they were perceiving and elicit their recommendation on how to improve online grocery services. Next. We grouped the community's recommendation into 7 major categories and mapped them to the original framework. Some recommendations have 2 colors here because they had specific recommendations that fit into 2 domains of the framework. So for example, for the third recommendation, more payment and cost saving options, we had allow WIC benefits to be used online concurrently with SNAP, as an example of more payment options, and to lower remove fees for delivery as a cost-saving option. Next, please. We also asked community members who will be the main actors or responsible for each recommendation and found that there were opportunities for policy improvement or change across all the 4 quadrants based on the recommendations from the community. It would also be important to engage grocery stores and delivery services in efforts to increase healthy food options and reduce deterrence. And finally, health educators were seen as key players for improving resources and build capacity of the community like SNAP-Ed. Next, please. So based on what we heard from the community, we selected intervention strategies to help us test whether recommendations applied across all the 4 domains could improve equity in online healthy food access. The intervention that we tested is in the context of online service, SNAP OPP. And for all participants, we did a community outreach to let everybody know about SNAP online and how to use SNAP online. And we waived delivery fees to all participants. Next slide. So then we were left with 4 interventions for testing, but we combined the online shopping education and interactions between consumers and online hire shoppers with a text messaging program aimed at improving perceived behavior control rooted in the theory of planned behavior. So to lower cost of healthy foods, we are testing a Double Up Food Bucks program online targeted at addressing loss aversion, rooted in the behavior economics, and a healthy default cart aiming to promote automatic thinking and address impulse purchases of unhealthier foods. We acknowledge that these relations may not be linear, as shown here, but the idea is to show that each intervention strategy would influence a single mediator, so we can identify which ingredient or which strategy that produced what effect. We have pilot tested each intervention strategy separately, and we now examine which combination produces greater behavior change. Next slide, please. But it's not only behavior change that we are measuring. We are looking for concurrent benefits that extend beyond healthy food purchase or health outcomes, such as nutrition education, perceived access to online grocery service, and improvement in digital literacy. We will also assess benefits across the interested parties identified by our community, such as policymakers, grocery and delivery services, and health educators. In our next larger study, we will incorporate cost of implementation and scalability considerations from the beginning throughout the intervention to ensure we identify intervention that is effective, readily implementable, and scalable to be delivered in real-world setting to produce a public health impact. So for scalability, for example, we are looking into fidelity, maintenance, and adoption from the individual and from organizations. Next slide. So as a summary, today I've shown you that we use an equity-oriented framework and community involvement to inform the design and evaluation of our intervention. We will consider mechanisms of hypothesized effects to identify which ingredient of the intervention are the most important for success. In our next larger intervention, we will evaluate impact beyond health-related outcomes and across the interested parties to estimate co-benefits. And I look forward to presenting more about our subsequent larger trial in a future webinar. Next slide. I wanted to end with some reflections. To achieve equity in our work in online healthy food access, we still need to understand other factors that have not yet emerged in our current work, but have been described in the literature. So websites are not currently available in languages other than English. So future efforts are needed to ensure services are offered in more languages. Despite the current policy to expand and try to expand SNAP OPP to other small stores, not only to chain grocery retailers, online grocery shopping is still not available in neighborhood stores, which are patronized by many families because they are familiar, they are there, and they carry culturally appropriate items. And finally, a possible unintended consequence of shopping online is the added opportunity for online targeted marketing, which is disproportional towards communities of color, as you heard from the talk from Brian Elbel. However, this is hard to control in an intervention implemented in a real-world setting, and we still need to understand a lot about it. So there are still some considerations and external factors that need to be understood and may get in the way of when we evaluate the impact of a PSE intervention. Next slide. Thank you so much for listening, and I look forward to discussing more in a few seconds. Thank you.
Angela, thank you so much. Those were fantastic kind of summary thoughts. Really appreciated that. So I'm looking forward to having just a kind of a short conversation as we get questions from the audience. Working for the American Heart Association, for an advocacy organization, I know how important it is that we could advocate for appropriations for the important implementation and outcome evaluation research that you do. However, it's often evaluation that gets cut first. Or is it written out of legislation, to save money or to move it to other initiatives. But I'm hoping, if you could help us make the case to policymakers on why this appropriations is so important, what would you say if you were called to testify? What would be in your comments? Brian, I guess I'll go to you first. Maybe I'll go in order of the presentations and just get everybody's.
Sure. I think it's a really good question, Laurie. And I think it's a really hard question to answer because, as exactly as you say, this is the part that gets cut first. I think what I would want to do is ask a question of them and say, what's important to you, maybe not in a hearing, but beforehand, what's important to you to understanding how this policy works? Because as we all know, it's not always the thing that's going to be most important to the health community. We want to see sort of like long-term sustained changes in health outcomes. And I think for many policymakers, they don't have that kind of timeline, right? They're running for election next year and need some results quickly. So it would be understanding a little bit more about what is it for them? Is it about, I want to see more kids eating school food? Is it about, I want to see that it's really having an impact in community X versus community Y? So I think I tried to turn the question to understand what's important to them and make sure, even if we're asking some of the other questions, we're asking some of the ones that are really critical to them as well.
Yeah, that's great, Brian. Thanks. A lot of the time, the first question we get asked from policymakers is, why should we be spending money on this? What's the return on investment? And so do you feel like you're incorporating that economic analyses, do you think, into your research? Because I know that's going to be really vital as we talk to policymakers.
Yeah, good question. I mean, I think we're trying to set the stage for that to happen next. We're sort of looking at generally, does it work? Right. And then if we understand if it works or not, then we can kind of go to the next stage of the question to, is it a good bang for the buck or is it kind of cost effective? So oftentimes we're trying to set the stage for, I think, the second things to know, is it even worth asking those questions before we understand if it really works or not?
Great. Thanks. Rafael, do you have some thoughts?
Yeah, so I am very engaged nowadays on complex adaptive systems work to help guide the scaling up of interventions that have been proven to be efficacious through RCTs and so on a small scale. And I am devoting all my advocacy time with policymakers to try to convince them that at that point, the vast majority of investments on evaluation should be done on process or impact evaluation. That through implementation science, we now have found very clever ways of integrating since the conception of a study implementation approaches that are low cost, that are sustainable, and that at the end of the day, they are nothing else but the quality assurance programs that all of these programs need to have in place for them to function properly, identify challenges on time and address them on time. That's what I would like to tell policymakers. I think those times and days where we were pretending that we could do randomized control trials at the country level and in real world conditions and so on are long gone. They didn't work. They will never work. It was a waste of money. And we really have to do something about shortening the amount of time, sometimes decades, that it takes to translate efficacy knowledge into large-scale benefits for our populations, especially the most disadvantaged.
That's a great comment. Thank you. And Angela, I'd love to get your thoughts as well.
Sure. I think I would add, with our current work, we are moving beyond just looking at efficacy and effectiveness, really looking at implementation in the real world setting with interventions that could be readily implementable because they are existing. So what combination of those interventions produce, sure, behavior change, but at what cost? And is it done with fidelity, right? So looking to implementation, process evaluation as well. And we are using mathematical models to try to estimate which intervention or combination of interventions are the most, the less costly or the best box, right? But with the best, it doesn't need to be the most efficacious, but maybe we are happy with a lower effect size for our main outcome, but with a lower cost, and for an intervention that's more readily implementable and adoptable by community organizations and policymakers and other stakeholders.
Thanks, Angela. So I guess I'll ask the audience too, because I really appreciate everybody's ideas from the panel. If you want to help us make the case to policymakers on why we need to fund this work within legislation regulation, put your thoughts in the chat or in the Q&A, because I'll take that back to our organization. So we have a bunch of questions coming in the Q&A, so I want to jump to the audience's questions now. Rafael, this is coming from Jamie. You discussed 3 phases of your research with Food for Moms. Were all phases funded through the USDA GusNet program, or did you leverage funding from multiple sources to do the work?
Yeah, so all the phases were funded by GusNet, but the funding was not enough for any of the phases. All the organizations have contributed with something in kind or material to make it work.
Excellent. Great, thanks. So this is, I guess, for all of you. Question is, what's next? What research do we need to actually shift obesity trends?
So I'll jump in since I was first last time, and we're going in the same order maybe. I think it's a lot of what we alluded to earlier. I think it's about thinking about not just single policies or programs in isolation, but combinations of things. I think that really is where we need to do the work, and being able to study those in a really rigorous way. I think that's going to be really important for moving the needle on this work. I think we know it's never going to be one thing, and we're going to have to think about combinations of things together.
Great.
So I don't know if this audience is going to like what I'm going to say, but I really think that we should focus much more on healthy lifestyle outcomes, diet, physical activity, stress management, prevention of smoking, and so on. and metabolic health. I think we are obsessed with obesity. We have seen what a bad idea it was to set goals based on obesity. It's incredibly tough to change once it happens. It's a intergenerational transmission. So I do like to keep measuring it to actually, see if our one of the big aspirational goals is being impacted. But I think we have really, really lost the most important thing here, which is to foster healthy lifestyles and improve metabolic health with or without weight loss and obesity. And the availability of the new drugs to address obesity has made this even more urgent nowadays, because the last thing that I think we want as a field is for the message to be, now you can behave whichever way you want. You can drink, smoke, eat junk food and so on, and just take these pills and you're not going to be overweight. There are very, very unhealthy ways of losing weight. So everything needs to be put into context. But I would say I'm not even sure we should be using obesity as a name of initiatives, to be honest with you.
Thanks. That's a great point. Angela?
I would, of course, agree with Brian and Rafael. I would add that we need to address the social determinants of health, move beyond obesity, look into psychosocial well-being, and other food security, other outcomes as well, and give maybe the same importance. And also be careful with and measure possible unintended consequences of our intervention, and be very mindful and designing, implementing, and evaluating with an equity lens in mind as well.
Perfect. Thank you.
Yes.
So this next question is for Brian, but anybody else could answer it as well. Brian, for natural experiments, the person who's asking this is, agreeing that using secondary data is important if you don't have data in your state, like school level BMI data. What data would you suggest using that could be accessed at the city or neighborhood level?
Very good and very hard question. Because I think we now see that you really do need some large scale data to be able to answer a lot of these questions when you're talking about small impacts that might build up. There are national or state level data sets that you could look at as well, some of which might have the right amount of aggregation if you look at them in a clear enough way. There's a resource at NYU Langone Health called the City Health Dashboard, which exactly tries to kind of aggregate and make available data at the lowest level that they can from a lot of these national data sources. So I would look to sources like that. But it's complicated, right? And I think oftentimes you might need to do a combination of these sorts of things to really be able to answer that question in a clear, compelling way. And I think it also speaks to the need to kind of get more of these data that are collected and that are accessible to a broader array of researchers and communities.
Excellent. All right, we've got one final question, and we've got to answer it quickly because we're down to 1 minute. What are your thoughts about working with industry, the commercial, business industry sector versus sometimes we take a more adversarial angle in population health? What would you say there?
Well, I have done it in very clear, compelling when it's a clear, compelling way and under a lot of sort of strict rules, if you will. For example, I never take any money from industry, but I have taken data from industry and gotten federal grants to use and understand those data. And I think those can be really compelling partnerships. And I think you're able to answer questions in a way that you are not able in other capacities. It's about finding the right partnership, right? It's about having kind of clear rules and maintaining academic integrity to be able to answer the questions that you feel are important. So, I think that there are times where those relationships don't work, but I think that there are times where they do as well.
So to me, the big picture is that a handful of companies produce 70% of the ultra-processed foods and sugar sweetened beverages that have totally inundated our food systems. Low-income people in our country are getting 60% of the calories from these foods. Those companies function in a total neoliberal economic system, maximizing profits no matter what at the expense of public health. It doesn't matter if it's infants, babies, mothers, women, older adults, low-income people, and so on. So without a serious, forceful regulation of their marketing practices, I think that it is extremely difficult to see how partnerships can be built with them, with trust, to actually end up benefiting equity and public health. Having said that, they are such an enormous part of the problem that there cannot be a solution if they are not engaged. So it's a very
Thank you.
complex question, and I hope I
Yeah.
don't offend anyone with my answer, but the data is very, very clear on their marketing behaviors and the enormous damage that they continue to do to public health globally.
Thanks, Rafael. I would love, Angela, to hear your thoughts on getting the hook on terms of our panel today. So just thank you so much to each of you. What fantastic presentations. It was wonderful to do this discussion with you and an honor to be here with you today. Look forward to turning it over to Dan.
Thank you.
Thank you all.